off.
Okay, then we can start it, I think.
Okay.
It's already 147 participants.
So good evening to all here today. Welcome on behalf of Ampok. We have been conducting this case presentations now for quite a while with the help of Dr. Boban and Arun Chandrasekhar. And it seems to be useful to the residents. I can see the numbers increasing with every case. Today we have Dr. Lakshmi Raj presenting an ovarian carcinoma case. She's a DM resident at RCC Trivandrum. We have with us Professor and Senior Consultant from Amala Cancer Institute, Dr. Sunu Siriak, and I shall be the other examiner, myself, Dr. Nikhil Haridas from Amrita Institute of Medical Sciences. Over to you, Dr. Lakshmi. You can start with the presentation.
Okay, sir. Good evening, everyone. Slides not. Good evening, everyone. Today I'll be presenting a case on ovarian cancer. A 58-year-old lady hailing from Trivandrum, who's a homemaker by profession, presented with chief complaints of abdominal pain on and off since 3 months, loss of appetite since 3 months, and early satiety since 3 months. Patient was apparently all asymptomatic 3 months back when she developed plain abdomen, which was localized to the lower abdomen, insidious in onset, dull aching type, intermittent, non-radiating, not associated with intake of food, not associated with nausea or vomiting, and there were no aggravating or relieving factors. She also complains of loss of appetite associated with early satiety. There were no history of significant loss of weight. There's no history of altered bowel and bladder habits, no history of melena or bleeding PR, no history of vomiting or hematemesis, no history of bleeding PB, vaginal discharge or mass per vagina, no history of fever, no history of yellowish discoloration of eyes or skin, no history of cough, chest pain, hemoptysis or breathlessness, no history of back pain or other bony pain, no history of any groin swelling or pedal edema, no history of any lump or pain in the breast. In past history, she is a known case of hypertension since 1 year on antihypertensive. No other significant medical or surgical illness in the past. Menstrual and obstetric history, she attained menarche at 14 years of age. Cycles were regular, 28 days, last for 4 days, moderate flow, not associated with pain. Patient was married at 21 years of age. She was a para-1, living one, had full-term vaginal delivery. Childbirth at her age of 25 years. She breastfed the baby till 2 years of age. And there was no history of any infertility treatment, no history of OCP use, tubal sterilization, or any other contraceptive history. The patient attained menopause at 48 years. There was no history of use of hormone replacement therapy. In coming to personal history, she consumes a mixed diet. Sleep, bowel, and bladder habits are normal. No history of any drug allergies. No history of smoking or alcohol intake. Family history, there is no history of any cancer in the family. Treatment history, she has not received any treatment for the current complaints. Coming to summary, she's a 58-year-old lady, para-1, living one, post-menopausal, who came with the complaints of pain abdomen since 3 months, associated with loss of appetite and early satiety.
Okay, so what do you think it could be?
Since she's a post-menopausal lady and with complaints of pain abdomen and loss of appetite for a short duration, the most probable diagnosis would be a malignancy. It could be a malignancy of adnexal origin, probably ovarian cancer, or it could be a GI malignancy. Otherwise, it could be a benign condition. It could be an abdominal tuberculosis. It could be a subserous fibroid, which is causing her pain and these symptoms, or it could be a
why do you think that adnexal would be the higher DD than GI origin malignancy?
She was giving a history of a lower abdominal pain, sir.
So that's possible with abdominal, anything GI also.
Other than that, there is nothing suggestive of adnexal in history, sir.
Then why did you put adnexal malignancy as the first DD? Then upper GI. The upper GI or lower GI?
upper GI is because in the classic presenting complaints, she does not have any altered bowel or there is no history of any symptoms of GI malignancy, any hematemesis, melena, or any other bowel. So, and the only complaint was a vague complaint of an early satiety and loss of appetite, which is classically seen more probably in a adnexal origin. So that is why I said.
It could be a mucinous peritoneal carcinomatosis. It could be a GI, upper GI stomach cancer also. But what makes you think that it's an adnexal first?
Because of the presentation not having classic symptoms of GI and the vague symptoms and short duration.
Epidemiologically, what is the chronology of ovarian cancer versus a colon cancer in your part? Number-wise, incidence or prevalence-wise?
In women, it is more common. Colonic ovarian malignancies are more common. Vague
Which is the
compared to GI.
commonest malignancy after in your area in females? In
Commonest
traumatic cancer
malignancy is breast, sir, followed by breast, followed by cervix, and followed by ovary in Indian scenario.
Was this patient from a rural or an urban setting?
She was from Trivandrum, sir. In a rural areas, like not the
in a rural area.
Not the.
So, would you consider cervical cancer an important DD in this patient?
Cervical cancer could be a DD, sir, but she does not give any history of any PV bleed or PV discharge.
Okay. So, in your presentation, you mentioned that there was a history of, there was no history of a breast lump. What is the significance of that in this abdomen presentation?
If in abdomen presentation, if we are suspecting like an ovarian malignancy suspected, then there is a role of there is a HBOC, the hereditary breast ovarian syndrome. So that is why a history of breast was asked.
Anything else?
Or it could be some secondaries.
From?
Secondaries from breast being a primary mets.
I request people not to put in the chat box for now. Once the question is over, you may suggest in the chat box. Okay. So, what is a Krukenberg's tumor? How does it present usually like?
Krukenberg's tumor, so usually they have a bilateral presentation with solid masses involving both ovaries, usually by transcelomic spread, commonly from stomach, other GI malignancies, from breast also.
Nikhil?
Does it always have to be bilateral?
Most
what is the
commonly, it's
common
bilateral
presentation
presentations
you have seen
of.
in RCC?
Excuse me, sir?
What is the more common presentation of the Krukenbergs, whatever you have seen till now? The GI cases. Most of them actually it will be unilateral only. Bilateral is more, yes, bilateral is classic probably, but still, most of the cases are still unilateral. It doesn't rule out. We can keep definitely metastasis should be one of your DDs. But what sir was trying to bring out by the history of both the, the incident, by incidents, you can justify when you are talking about DD at the history level, and ovarian malignancy is reasonable to justify by the incidence itself. Second thing, what is the significance of the urban versus rural for your case? Why did sir bring that? Why is that point brought out?
So the urban, it is, we can have a diagnosis of a endometrium, like uterine malignancy would be.
It is, of course, a postulation, or rather than our association. Generally, probably ovarian malignancy is considered a developed country's disease or a urban disease. That would be the inference, or how we'll try to justify at this point with only the history. Of course, I would still not, with your history, I would still not put what is probably against, let's say gastric malignancy. Because same thing, early satiety, Metastatic disease, abdominal disease, you can have lower abdominal pain. Krukenberg can explain the lower abdominal symptoms, or even the peritoneal disease can explain it. What would probably be a little more striking feature for a gastric disease? Did the patient have significant weight loss?
Weight loss. In this case, patient doesn't have a significant weight loss.
That is how probably you can bring it one step below, but you cannot eliminate it as of now. Sir, anything else?
And one last thing, what is the lifetime risk of ovarian cancer and adnexal cell cancer in Indian population, in Indian female?
Lifetime.
You have heard that terminology of lifetime risk assessments and all.
Yes, sir. Yes, sir.
What is the lifetime
I'm not
risk
sure,
of
sir.
an Indian adult for any cancer?
Ovarian.
Okay, just find it out. And ovarian specifically, it's only around 1%. Anyway, go
It is
ahead.
1 to 1.2%. Do you
Yes.
just to complete this question, because you had brought out a family history? If there is a BRCA, what is the probability or the relative risk of a patient having a BRCA1 developing an ovarian cancer over
It is for
5 decades
around
of?
50 to 60%, sir.
Okay.
BRCA1.
Okay.
BRCA2?
BRCA2 is
Okay,
around
I'll accept that.
13 to 30%, sir. 30%. 13 to 30%.
BRCA2 for ovary or breast?
For ovary, sir.
Okay.
BRCA2 ovary.
15 to 20%. Okay, go ahead.
Can I go ahead, sir?
Yeah.
Coming to general physical examination, after obtaining consent, patient is examined in a well-lit room. Patient has an ECOG performance score of 1, weight of 65 kg, height of 155 centimeter with PSA of 1.6 and BMI of 21.7 kg. Her vitals were normal. There was no pallor, icterus, or pedal edema. No supraclavicular lymph node or inguinal lymph node. Bilateral breasts and axilla were normal. Coming to per-abdomen examination, after obtaining consent and exposing the patient from nipples to mid-thigh, the patient is examined in a supine position. On inspection, the abdomen appears distended with fullness in the lower abdomen. Umbilicus is central. Skin over the abdomen appears normal with no visible scars, sinuses, or dilated veins. No visible pulsation or peristalsis. Respective quadrants move equally with respiration. No fullness in the flanks. External genitalia and hernial sites appear normal. Palpation. Inspectory findings were confirmed on palpation. No local rise of temperature. Abdomen is soft. No generalized tenderness, guarding, or rigidity. Abdominal girth is 75 centimeters at the level of umbilicus. A 10 into 10 centimeter mass felt in the left lower abdomen, extending till midline, occupying the left iliac fossa, hypogastric, and umbilical regions. The lump was smooth, firm in consistency, non-tender, with ill-defined borders and restricted mobility. The lower extent of the lump could not be palpated, and the upper extent is reaching just below the umbilicus. There were no other palpable organomegaly noted, no cough impulse at hernial site. Coming to percussion, there was a dull note on percussion over the lump. There was no shifting dullness. Liver span is 13 centimeters. On auscultation, normal bowel sounds were heard. Coming to genital examination, the external genitalia appears healthy. Urethral orifice appears normal. On post speculum examination, vagina and cervix appears healthy. For vaginal examination, cervix and vagina is healthy. On bimanual palpation, a mass was felt in the adnexa. Bilateral phonics was full. Coming to per-rectal examination, rectal mucosa is free, no nodularity, sphincter normal too. Coming to
Wait,
systemic
just previous slide,
examination.
please. Previous slide, please. Anything more about the PV examination?
Sir, on PV, vagina and cervix was healthy. On there was on bimanual palpation, mass was felt. In POD, there was no nodularity palpable, sir. So I have not mentioned it.
Okay, next.
Coming to systemic examination, just
Skip.
bilateral. So to summarize, a 58-year-old paravan living one postmenopausal lady presented with complaints of pain abdomen since 3 months associated with loss of appetite and early satiety. On examination, a 10 into 10 centimeter mass felt in the left lower abdomen, extending till midline, occupying the left iliac fossa, hypogastric, and umbilical regions. On pervaginal examination, a bimanual palpation, mass felt in the adnexa with bilateral fornix pulmonale.
Okay, now what do you feel like?
Sir?
Now, what do you feel the differential diagnosis would be like?
After the examination, after examining the patient, a mass was felt in the left lower abdomen, and the lower extent of the mass was not palpable. And on PV, the same mass was felt in by manual palpation. So probably, this is most probably it's a tumor of adnexal origin, could be arising from ovary, and my most probable diagnosis would be a carcinoma of ovary.
Ovarian malignancy. And the second DD?
Second ED, it could be a colonic malignancy, which is, or third DD would be a carcinoma endometrium with.
Okay. Okay. How are you going to evaluate this?
So
Next
first,
slide,
I would
yes.
like First, I would like to confirm my diagnosis by ordering for an ultrasound abdomen. Also, I would like to ask for a tumor marker CA-125, CEA, and along with a full blood work of CBC, LFT, RFT. And based on my ultrasound findings, I would like to go ahead with the CT, thorax, abdomen, and pelvis.
Okay. Have you done those?
Yes, sir.
Nikhil, you want to ask something about the examination finding?
Yes, sir. That's what. So I think the DDs here can be narrowed down. Why would you think of a colonic mass when you're bimanual, which is relatively maybe 80% sensitive, is showing a probably something arising origin. The way you can probably, if the examiner keeps asking for further differential diagnosis, is probably show up it as a Krukenberg with the primary, the findings of the primary not being evident. So probably something from the GA. I mean that should be enough. Otherwise, the rest of it is fine. Please proceed with the
Yes.
investigation.
On ultrasound abdomen, there was an irregular heterogeneous pelvic mass of 16 into 7.5 into 7 centimeter in the midline. Multiple cystic areas were seen within the mass. Irregular margins were seen with projections within the mass seen. Mass is extending to the left lateral pelvic wall with irregularity noted along pelvic muscles. Mild omental caking with hypoechoic nodules extending into the omentum. Uterus and left ovary were not separately visualized. Mild ascites was present. Coming to tumor markers, on CA-125 was 760 and CA was 1.1.
Okay, just go to the previous slide. Forget about the CA markers. Previous one. Previous one, yeah. With this finding, what do you think means what are the pathological subtypes of an adnexal mass that you would suspect like?
Since the
yeah.
ultrasound is characteristic, mass is having multiple cystic areas, irregular margins, and masses also there is mild omental caking, omental nodules. And since the ovary is not separately visualized, most probably the diagnosis would be a ovarian malignancy. It is more favoring the malignant side than the benign on ultrasound.
Yes.
Why
Among
do
the
you say
malignant
that?
side. Yes, go ahead. Go ahead.
Why would you? What else would you? What was a particular point in your ultrasound to say? Let us say you don't have the other features. Probably you're seeing some adnexial lesion. You are seeing a complex lesion. What would put it more in favor of malignant than benign in this? What are the generally commonly things which we look at in the ultrasound?
In ultrasound, usually it would be a complex mass, multiple papillary projections would be seen, solid areas would be
I
present
think we
along with
want more
cystic,
of solid areas rather than pure cystic areas. Yes.
cystic areas, solid areas than cystic areas. And the mass would be a tumor, usually more than 10 centimeter, presence of ascites.
Okay. Presence of ascites and probably mental involvement is fine. And also papillary project that can be seen in the ultrasound. All those probably would favor a malignant rather than benign, right?
So what are the other pathology, means what is the pathological subtype that you would expect here?
Most common subtype would be a serous carcinoma. So I would be expecting a high-grade serous carcinoma.
Points in favor
Mhm.
of a
That is the
high grade and serous. Points in favor for both.
serous carcinoma is the most common presentation. So in the ovarian carcinoma, around 60%. So I would think of it as a serous carcinoma.
And
No,
high
in
grade.
your patient is what sir is asking. With your history, what is favoring a high grade
Okay,
and
my patient, because usually borderline tumors are seen and low grade tumors would be seen in a younger age group, sir. My patient is a postmenopausal lady, so I would think of a high grade.
also not a long-standing history, right? Actually,
On
relatively
short
short
history.
history. Sure.
And what are the other subtypes that you expect in ovarian cancer commonly?
The other subtypes would be, sir, endometrioid, mucinous, clear cell.
So what would be the presentation of a endometrioid carcinoma, a low-grade endometrioid carcinoma? History-wise and finding-wise, what would you be the presentation of a low-grade endometrioid ovarian cancer?
Low grade endometrioid would present with um, maybe a history of a PV bleed would be seen, or
Sometimes could be associated with the uterine endometrioid also. Okay. PV bleed is more common, might be with endometrioid. That's right then. And how often would you get an omental caking and all this ascites and all in endometrioid?
this it will in a low grade we would not be getting all these features if it's a low grade.
Okay. Okay, go ahead next. CA125 was elevated.
CA125 was elevated, so CA was in the normal range. Coming to
Okay,
CT, a large lobulated CCT, a large lobulated heterogeneous and enhancing soft tissue mass lesion arising from the left head nexa, reaching above the umbilicus, measuring 16 into 12 centimeters, irregular, non-enhancing necrotic areas and small cystic areas, cystic components were seen within the lesion. The left ovary is not separately visualized. The lesion has invasion to the posterior myometrium, short segment of sigmoid colon with multiple peritoneal deposits, largest 3 to 4 centimeter, diffuse thickening and fat straining of the greater omentum, probably metastatic deposits, mild ascites, no significant lymphadenopathy or hepatic lesion, right ovary appears atrophic, no focal lesion seen.
Invasion to posterior myometrium. Okay. Next.
I will come back to
Yeah.
the slide a little later. You can go to the next, what you have done next after this report.
Sir,
For this
actually,
patient, what did you do?
after the CT, we had a discussion with the gynec oncologist regarding the resectability of the patient, considering the patient for a primary cytoreductive surgery. And following that, since the patient was not considered for an upfront cytoreductive surgery, patient was referred back to us for considering a neoadjuvant chemotherapy. So before getting the neoadjuvant chemotherapy, we ordered for a biopsy from the mass.
Okay.
What would be the
The-
points,
Right.
why do you think so one actually just one small point I think in such a thing when you reach this point in discussion, maybe a much neater way to put that, we discuss this at this point with this information, we discuss the case in a multidisciplinary team, including the gynec oncologist. and decided that the patient is unresectable or is currently may not be a candidate for primary cytoreduction. What are the common causes for the, what are probably the features or factors in deciding on unresectability in case of ovarian cancer, especially high-grade serous cancer?
The
In these images or
mostly
by CT or clinically?
CT, if there is like if the surgeon feels they cannot achieve a cytoreduction, like an arterial resection, it could be diffuse peritoneal mets, route of mesentery involvement. Then it could be extensive liver involvement and or extensive miliary lung involvement, diaphragmatic involvement. All
Okay.
these or any bowel resection which would lead to only 150 centimeters of short bowel syndrome. So such cases when the surgeon feels it is they cannot achieve a complete cytoreduction, then we would like to do it.
So
Okay.
extensive, yeah. So this with this CT scan, I still feel that this is a sigmoid colon malignancy going into the going into the ovary. Why didn't you prove it first before sending the patient to a gynecologist? There is infiltration into the sigmoid colon. Did you do anything to prove that?
Sir, I would be doing a biopsy to leave it, see
Biopsy will
what is it.
both give you an adenocarcinoma report, right?
Based on the IHC, or else I would
What
go ahead
else?
with the colonoscopy and
So why didn't you do a
to see.
colonoscopy? Why didn't you do a colonoscopy before deciding upon the surgery? Because if it's a colon cancer, suppose this is a primary colon cancer with the same picture, what would be the stage for the, and what would be the management approach for this patient?
It would
Would
be
you
a,
still go ahead with the, yeah?
I would, after confirming it in the biopsy, I would be going ahead with the neoadjuvant chemotherapy.
Or for a colon cancer with ascites, omental deposit, etc. Okay, go ahead with the next slide. So first differentiate whether it's a primary colon cancer. Always anything that comes near to the colon, without even if it's in a very clear adnexal mass, try to get a lower GI endoscopy. And if there are multiple deposits, which is suspiciously looking at an upper GI endoscopy also. Many times this can be a mimic, many times this could be a feature of a Krukenberg also.
Always our CA 125 by CA ratio need not give the true picture. As Sir pointed out, if you say anything in the radiology, also please keep radiology in the mind and do a scopies if required. OGD and colonoscope.
Because if there is no, if adenocarcinoma might be the biopsy finding, which could be there with the colonoscope, colon malignancies also. So Nikhil was mentioning something about the CA 125 ratio or something. What is that?
Okay. Sir, if the CA 125 to CA ratio is more than 25, then we would go, most probably it would be a ovarian origin. And if it is less than 25, it would be a colonic or GI.
Okay, next slide. Next. Slide is not moving.
Are the slides moving at your end, Lakshmi?
Yes.
Yes.
Biopsy from the peritoneal mass suggestive of a high-grade serous carcinoma. CK7 was positive, CK20 was negative, PAX8 was positive, WT1 was positive, and P53 was positive.
Okay,
What do you mean by
so
positivity of P53?
If
Even a low grade will also show positivity when you do a IHC. Low grade serous.
usually
What
when
do you
if
mean
a
by
low grade
positivity?
shows positivity, then we usually consider it as a
So
high
what is
grade.
the terminology? So when somebody is asking you, whether probably is a, what is, so the real question, what is the terminology used when you talk about P53 when you're reporting P53 by a IHC?
Terminology.
What are we looking at in the P53 protein? Is it the protein aberration in the protein or is
Mutations
it
are
the retained? So that's what. So we'll say wild
mutation,
type and mutated.
mutated types.
So
If
what
it
would
was
be the
wild type,
feature?
what would you think about? Same features, but wild type.
The prognosis would be better if it is wild types.
Okay. Any other marker you would add to maybe arrive? I mean, let us say clinically it was not. I'm not talking about the same patient. I'm just talking with the IHC alone. Wild type P53. Would you think of some other IHC markers to add to probably get a better differential diagnosis with the pathology? What about the hormone receptors? Would it be worthwhile adding in these cases? If it is strongly positive, it's showing
ER,
strong positivity, would I change my diagnose? Let's say WT1 is also
a
negative.
uh, low grade usually have a ER.
WT1 can be positive, it's usually not positive, but can be positive in 10-20% of low grade. But the high ER positivity and the wild type P53 will work in favor of a low grade.
Low grades.
What are the other, sir had asked you the other subtypes. What would be the IHC pattern for them?
Sir, if it is endometrioid, it could be again there will be a CK720 negative ER expression. It could be there could be a P10 expression, sir, Vimentin positivity.
Okay.
Or if it is a mucinous, it would be usually having a CDX2 and CK20 positivity could be.
Yes. Clear? Anything info clear? Okay.
Okay, go ahead.
That's all I have, sir. Slides.
So now you have the diagnosis that you have a high-grade serous carcinoma and your gynecologist told that this is inoperable. Is there anything
Yes, sir.
additionally in the pathology that you would like to do?
I would like to go for a somatic and a germline BRCA mutation, BRCA testing
Why
before
both?
starting for it. Because
Why both? What is the advantage of doing both? The
actually, if
patient
it
will
is,
say that if there is no added advantage, why should I spend double the money?
ideally, we can go ahead with the germline mutation, sir.
And
Blood test. The
And?
advantage is that if I can consider in maintenance, if the patient achieves a CR or PR following cisplatin-based chemotherapy, I can consider for PARP inhibitor in maintenance. That is why
in first line?
first line, sir, first line.
You told that germline you would do first. If you get a negative wild type germline, then what will you do? Would you still do a
Germline
somatic
negative,
or
then I can go for an HRD testing, sir.
what is
There is
HRD?
a my choice myriad my choice test. I can offer that to the patient.
What is HRD?
HRD homologous recombination deficiency, sir.
That I do. What is it?
There in that we test for the genomic instability. Basically, there is a score for that, and if the score is GIS is more than 42, it becomes a HRD positive, and we can consider for.
So somebody came and told me that why don't you do HRR only? What is HRR and what is HRD?
That is repair, sir. Is recombination.
Homologous?
Recombination repair.
What is the
I'm
difference
not sure,
between
sir,
both
about it.
and which? Okay, so that's very important in the PARP era. What is the best choice in prostate cancer and what is the best choice in ovarian cancers? Okay, so you did that also, and did you do that for this patient?
No, sir. Patient
PRC,
was.
no. Patient was?
Patient was anyway would not afford a PAP, sir. So we did not get we discussed the option with the patient, but then.
Okay. Any other implications apart from olaparib or PARP inhibitors?
Any
Okay,
other?
next. Okay. Okay, we'll forget about it. So now the surgeon sent the patient back to you. You did a colonoscopy, you did a lower GI endoscopy, everything came normal, and finally your diagnosis is an upfront unresectable high-grade serous carcinoma of the ovary. In the CT scan, did you do the CT scan of the thorax?
Actually, we got it later, sir. We got it done
what
before
did it
starting
show?
to. It was normal.
What did it show?
It was normal, sir.
No
There was no pleural
effusions?
effusion. No effusions.
No pleural effusions. Okay. Now tell me, how are you going to manage this patient?
So I would like to go ahead with a neoadjuvant chemotherapy with paclitaxel and cisplatin, sir, and carboplatin, sir. Paclitaxel 175 mg per meter square, carboplatin AUC 5. I would like to give for 3 cycles, followed by radiological assessment reevaluation, and considering for feasibility for interval debulking
Carboplatin, what is
surgery.
the AUC? Carboplatin, what AUC?
AUC 5, sir, 5.
Is that the
We are
standard?
giving 5, sir, here. 5 to
Is that the
6 can be
standard?
given.
Okay. So all of a sudden, some other surgeon comes and tells you that he can operate it and give you an R0 resection or a complete debulking, he can achieve it. But there is another person coming and telling you that it's better to go for neoadjuvant chemotherapy. What is the advantage of a neoadjuvant chemotherapy in this patient? If both of them, there are surgeons who can give you a complete debulking.
So there's a point. So
Actually,
the
there is no
outcomes.
much outcomes
Please,
between
please.
there is like the outcome between primary cytoreduction and with interval debulking. There is no much difference in PFS or OSS. So if it is better to achieve a CCO after chemotherapy, I would go ahead with chemotherapy and then consider for a deep
Why?
interval
If
debulking.
there is no advantage, and the surgeon is very confident that he can do it, then why should you still go for NAC? What is the advantage
There
of
should be
going
some other
for NAC?
additional other than surgical. Is there any other implication or addition or indication for neoadjuvant?
Because we can consider giving the patient if during interval debulking we can consider patient for a HIPEC if we are giving NSCT.
HIPEC
That is
in an NSCT. HIPEC in an NSCT. Okay. What are the other peritoneal guided therapies? You mentioned that this
intraperitoneal
patient can't
chemotherapy,
afford
sir.
intraperitoneal chemotherapy. That is a cheaper option than HIPEC. That can be given upfront. Why can't you do that?
There has
What is the
been
difference between HIPEC and
no much
IP chemotherapy?
in HIPEC. Hyperthermia is also like the chemotherapy. In hyperthermia, action of hyperthermia synergistic with the intraperitoneal chemotherapy's action. So, and the intraperitoneal chemotherapy as such was seen to be very toxic, even though so.
Have you used intraperitoneal chemotherapy? How is procedurally both these things done? HIPEC and intraperitoneal IP?
Intraperitoneal chemotherapy, if it is planned during surgery only, they place the ports, and later there is a schedule like we give paclitaxel 135 mg per meter square to a 24-hour infusion, then followed by cisplatin 100 mg per meter square on day 2 IP, and then on day 8 intraperitoneal paclitaxel.
What is PIPAC?
In HIPEC,
Not
following
HIPEC, PIPAC.
optimal
PI. PIPAC.
Yes.
HIPEC.
PIPS.
That is, sir, pressured.
Okay. So, one advantage with NSCT that you find is that you can go for a HIPEC therapy if needed. Anything else?
Tumor
What are
biology
the
response to
post-op?
chemotherapy.
Response to chemotherapy can be understood. Okay. What are the post-operative morbidity and toxicities or side effects in between these two?
Post-primary cytoreductive surgery, the post-operative morbidity is high, sir, compared to an interval debulking surgeries.
Like what?
Most
This patient could potentially end
because of
up with a
extensive
stoma
removal,
bag.
wound healing, delay lymphedemas, and
He could end up with a stoma bag or even a cystostomy bag. Fistulas or infections or all those things might be higher. Wound healing, hospital stay, everything is higher with those things. So even if there is no OS-PFS advantage, still NACT is the preferred choice for this patient for a better surgical outcomes. Okay, so Nikhil, anything?
No, sir. We can move.
So did this patient go for surgery, neoadjuvant chemotherapy?
we have just started, sir.
Okay, what agents did you use? Paclitaxel and carboplatin.
Paclitaxel carboplatin.
So, if somebody comes and tells, why don't you use docetaxel instead of paclitaxel? Would you say yes to that?
Sir, in patients having neuropathy, peripheral neuropathy, or we can consider for docetaxel based on the SPOTROC trial, there is non-inferiority for docetaxel.
What was the thing that was more in that arm?
The
trial, what was the thing that was more?
thrombocytopenia and
Myelosuppression was much more
hematological
in the
myelosuppression would
docetaxel.
be more, sir.
Okay.
With
Now, somebody else comes and tells you that why don't you give her dose dense paclitaxel and carboplatin?
Sir, in dose dense, there has been only benefit seen in some of the Japanese trials, sir, with dose dense.
Or you don't like Japanese? You like only Americans? Japanese does the trials very nicely. They do it very excellent.
So, what was the benefit in the Japanese trial? Very specifically, what was the benefit?
Even OS benefit was there in, sir, in some trials with weekly giving 80 mg per meter square weekly.
Yes,
and
so
also PFS, how much was
sir?
almost 10 months additional or something like that, right? I think 16 versus 26 or something like that.
PFS was 55 or something like that. Yeah, it was a huge difference for them, PFS, and a very significant OS difference. So which trial showed that it was not so great, that you want to go ahead with? JGOG trial showed that there is a major advantage with dose dense therapy, but you still don't want to, based on which trial?
MITO GOG trials, sir, it did not show advantage.
MITO GOG, anything else? Or some ICON trials? Okay, so that trial showed that there was no great benefit of these things.
Okay.
And what was the additional problem in the dose dense arm? Generally, which is better tolerated?
The tolerability, actually, weekly paclitaxel of 60 mg was actually tolerated in an elderly population based on the EVOC trial. So,
but that's not the dose given.
in EVOC trials, sir, in elderly frail population.
That is something different. That is not the dose. So what is the dose used in JGOG or in ICON?
That was 80 used, sir. 80 was used. 80 mg per meter per weekly. Day 1, 8, 15.
There's significant increase in neuropathy and adverse effect fatigue towards the end of the cycle. Definitely in the dose dense compared to 3 weekly. Those would be the reasons why we probably may not prefer. You have one trial showing a good result, you have another trial negative. Maybe one more trial can help us settle the bet. But that still is an option for us. In select patients, you can use it. What you're talking about is the elderly patients, it's reasonable to use a lower dose of paclitaxel. Even if you give 3 weekly also, you can use lower dose. There's another trial which have done the 135 mg per meter square 3 weekly dose.
MITO 7.
MITO, correct.
So suppose this patient was a BRCA mutation, BRCA1 mutated patient. Would you consider just putting her on olaparib as neoadjuvant?
Neoadjuvant, sir? Like, I won't consider for a neoadjuvant. Sorry, after NACT, if she has a response, a CR or PR, then I would consider as a maintenance, sir.
After NACT,
What
you
about
don't want adjuvant.
bevacizumab?
What, sir?
Anything else that you would consider along with paclitaxel?
Yes, sir. For bevacizumab can be added and then continued for maintenance also, sir.
For this
When would you
patient?
have preferred to add bevacizumab? Or will we add bevacizumab to all the patients? Is there any particular criteria to
Usually,
select a patient in a neoadjuvant setting?
usually we add bevacizumab when we feel the patient is not having a good response or there is refractory ascites on NACT, and we add bevacizumab.
You mean you
Refractory
add it
ascites.
after? You mean you add it after the surgery?
After, like if we expect the patient to have, like not after, sir, if we expect the patient to have a like based on clinical suspicion, then we usually add.
So, which was the trial that showed that bevacizumab might be beneficial in upfront setting? Because their
So there
selection
is
criteria is something
GOG
that we could
218
follow.
and GOG 218 and Icon 7 trials, sir.
So Icon 7 and GOG almost came up with a nice way of how to identify patients who might benefit this thing. Which were the
What
higher
was
risk
that?
patients who would? Yeah.
What was that? Especially GOG
High-risk
had
patients were
studied those
included
patients.
in GOG 218, sir. High-risk patients were in 218.
What is high
Icon
risk?
7,
What do you
like
mean by high risk?
the stage 4 patients, like not completely resected, stage 3 patients, all those were in the GOG 218, sir.
What do you mean
In
by
other ones,
incomplete
they had two.
resection? In what is the definition for incomplete resection? Incomplete. That means gross
I think, sir,
residual. That
more
means
than
something like
2.5
suboptimal debulking.
suboptimal,
Something
more than 2 or 2.5 centimeters, sir.
2 centimeters. Ideally, definition wise, and when we say more than 1 centimeter, but then here it was 2 centimeters.
2 centimeters.
So, is there anything that would make you think twice before starting bevacizumab for this patient?
Neoadjuvant.
Neoadjuvant, she is already a hypertensive patient, so that is one factor. And
That can be
then,
managed. Okay.
okay, another would be since there is a colonic invasion of fistula or could happen in the patient or bleeding or
So those risks
even we
are a
take
little
up
bit higher with this patient. And when would you stop surgery before surgery? When would you stop a bevacizumab therapy?
sir, 4 weeks, like almost 1 month prior to.
Why? At least 6 weeks. Why?
At least, because it interferes with the wound healing and surgery and wound healing complications. Sir.
Why?
So prevent that.
Why? Why paclitaxel does not interfere, only bevacizumab interferes?
Because our anti-VEGF action
And what would be the dose of bevacizumab?
dose would be 15 mg per kg, sir. 3 weekly.
Have you given 15 mg per kg for any patients? It's might be a bit toxic, but okay. Okay, now this patient suppose she completed 3 cycles of NACT.
Okay.
And her CA125 started coming down very nicely. And you send her for surgery. They did a surgery, and on the table, the surgeon called you and told you that the patient does not have any financial issues and concerns for anything. He told that he couldn't remove everything. There is a little bit something here and there in the peritoneum that is left. So shall he go for a peritoneum directed therapy like a HIPEC for this patient now itself? He just wants your consent. What would you say?
Sir, a HIPEC ideally has to be done only after complete cytoreduction. So when it is a CC0, I would not.
So you say that it's better not to do that.
Better not.
And then he closes it and continues, means the sensor back to you. How would you continue managing suboptimal cytoreduction? post NACT? How would you manage?
I would like to continue the adjunct remaining cycles of chemotherapy, sir. 6 cycles. Complete
Okay.
6 cycles of chemotherapy.
And keep
And
on the
then
follow.
I would keep the patient on, if the patient has a, I would like to give a maintenance agent to the patient. So if it is BRCA positive or HRD, I would like to go ahead with
The
PARP
patient is
inhibitors.
BRCA positive and had a suboptimal resection. Which one would you prefer, olaparib or bevacizumab, or both?
According to the Polar trial, we can give both olaparib and bevacizumab.
You feel something?
Okay, so we have, let's say this patient has BRCA. I'm just moving the thing
Yeah.
along to the next. Most of our discussion do not end up at that thing. How would you? This patient has completed a chemo. Let us assume she has a HRD. She has a BRCA mutation. She got some compassionate grounds for olaparib. She was optimal. This thing. So, how long would you keep her on treatment? She is completed use.
Olaparib, I would like to continue for 2 years, sir. Based on
Okay.
Solo 1 trial, I would like to continue olaparib 300 mg/d for 2 years.
What are the issues generally you have in these patients who are on olaparib?
Most commonly, they have the fatigue, asthenia, nausea, vomiting symptoms, hematological toxicity, anemia, and also there is
GI
a
also
risk of
might be there.
AML-MDS. Risk of AML.
How many patients in solo had an AML MDS developing?
Sir, in of 1 to 2% in the first line.
Only hardly 3 patients, but in the other arm, there was hardly any patients. So that is still significant. You need to keep a close watch on those things. But
So this
suppose,
patient,
yeah, well,
sorry, this patient hypothetically completed her, probably, let's assume she didn't afford olaparib. That's generally what we are seeing. She was on follow-up. How did you follow up the patient? How would you follow post
For,
adjuvant?
sir, I would follow up the patient every 2 to 3 monthly for the first 2 years with a CA 125 and clinical examination. And following after that, in the year 3, 4, 5, I can give a 6 monthly follow-up, sir. Let's say.
Is there any is there institutional protocol for imaging in epithelial ovarian cancer?
So we
Do you do,
usually
some people do every
consider
six
imaging
months for the
only when
first
the
2 years?
patient is. We usually do not consider, sir, if the patient is clinically symptomatic, or then only we consider for an imaging, so regularly.
Or rise in your
Right.
tumor markers,
Serial
right?
rise in.
Okay. This patient at the end of 6 months from the last chemo, her CA 125 went up to around 120. What would you do then? It reached a baseline of maybe 15 or something. And even the first follow-up also, it was around 25. Now it has reached 120. You do a CT scan, there is no evidence of disease.
So I would keep the patient on follow-up, sir. I would not do any intervention. 3 monthly serial repeating the CA 125 and seeing if only the patient clinically develops any symptoms, then only I'll go for an imaging, and if symptomatic, consider for a second line.
would you increase the dose of bevacizumab?
If she was on maintenance, would you consider increasing dose of bevacizumab by adding something else at that time?
Using the dose, not sure, sir.
Okay. Well, so which is the other agent other than bevacizumab which could affect the VEGF, which was tried as a maintenance therapy in ovarian cancers? Sometimes we still
I
keep on
think
using those things.
It was there in NCCN quite a while back.
Nintedanib,
Yeah, done.
multiple.
Much more accessible, much more cheaper than bevacizumab, actually, even cheaper than the generic bevacizumab. It was there as a category 3 recommendation quite a while back in NCCN, then they removed it due to some other data. Agorova
Endoxan
trials. No,
That's
pazopanib.
hardly used.
Pazopanib.
Pazopanib.
Pazopanib we were
should be
using.
the Trazodone.
So now, like what Nikhil said, the patient was kept on follow-up, and after 3 more months, the CA-125 rose again, and then you did an ultrasound, and then you saw some other peritoneal deposits. A little bit of ascites also developing. What would you do?
I would see for the symptomatic. If the patient is clinically symptomatic, then only.
Yeah, she has some vague diffuse abdominal pains and a little bit of occasional constipations.
So, since the DFS is only around 3 months, and the patient is symptomatic, I would like to and I cannot consider for a resection because it's only 3 months. So I would consider for a second
Not
line.
3 months, totally 9 months, total 9 months.
Totally 9 months. DFS, if the patient is having a DFS of 9 months.
What is the word? What is the more commonly used terminology for ovarian cancer in the setting? What is the word used with?
Platinum sensitive, platinum
Platinum-free interval,
like
PFI. That is
PFI,
what you should comment about.
platinum printing.
Yeah, then what would you consider for?
I would consider for a second line chemotherapy, sir. For lipodox carboplatin.
You do a biopsy before that?
No, sir. Ideally, we usually do not do a.
That's okay. So you want to try lipodox carboplatin. But patient's relatives, somebody inquired somewhere and they told, why not use paclitaxel itself? What is the advantage between paclitaxel versus lipodox carbo? Which trial
In the
proved that?
Calypso trial, we saw PFS benefit was better with lipodox carbo compared to paclitaxel. So we usually give lipodox carbo and.
Okay. And lipodox carbo. Okay. By the round, you started the lipodox carbo, and what is the schedule of lipodox carbo like?
Lipodox would be given for 30 mg per meter square. Carboplatin AUC 5 given 4 weekly.
And suppose you completed the 4th cycle, and during the 4th cycle, your daycare nurse comes running to you and tells you that the patient is having severe breathing difficulty and hypotension, etc., etc. What would you do?
It could be a lipodox can cause hypersensitivity, sir. And also carboplatin in the later cycles, carboplatin also can cause hypersensitivity.
What is more
Which-
likely? What is
This
more
is-
Could be
common in your
lipodox,
practice?
lipodox.
Usually by around the 10th or 11th cycle, you're almost highly likely to get a carboplatin reaction.
Carboplatin has a delayed hypersensitivity on this. This is classic. We see that more often than lipodox.
How would you manage it?
So based on the grading, if the patient is having like flushing or itching and rashes, I would like to stop the infusion, and I would like to give Avil and an Efcolin injection, and likely consider the later start in a slower rate.
And then, what is the chance that you will get a reaction with carboplatin if you re-challenge it? What is the difference between a paclitaxel reaction and a carboplatin reaction?
Paclitaxel reaction usually occurs in the first cycle, sir. Within first 10 minutes of infusion usually occurs, and carboplatin usually occurs after later cycles.
Then re-challenge?
Re-challenge is done, sir. Carboplatin.
It almost always re-challenge
consider for more.
paclitaxel. Carboplatin re-challenge should be very cautiously done. unless you are really a very good and you have to resensitize the patient, desensitize the patient nicely against, then only you should start if carboplatin is inevitable. Otherwise, it can be deadly. Carboplatin reactions can really be deadly once the reaction starts. Okay. Now, suppose this patient, after another, you had a partial response for some time, and after another 6 months, the patient relapsed. You did a repeat biopsy, and the biopsy showed that she was BRCA1 positive. How would you treat her?
This is, sir, in the
So she
second
has taken
line.
partly carbo. She has relapsed after 9 months, taken PLD plus carbo, and then she has relapsed again. This time you decide to go for repeat biopsy. It is showing a BRCA positive or HRD in the biopsy.
I would not consider giving a PARP inhibitor in this setting, sir, because the there was PFS benefit, but the OS benefit was not seen, so I would not consider giving PARP.
In a disease like ovarian cancer, why would you hate PFS? Ovarian cancer is a disease that keeps on relapsing again and again and again. So after one line, most of the patients will end up receiving almost all the drugs that's available. So why shouldn't you take an advantage of PFS? What is the reason why this meant? Which trial was the reason why this was not used for treatment?
Based on the NOVA trials.
It was previously approved. Did you know that this was previously approved?
Yeah. The niraparib was previously approved. So, based on the ANOVA OS was detrimental.
Because the comparative
arm
did.
Sir, go ahead, sir.
Go ahead.
Also,
so as sir mentioned, it is the olaparib trial in this setting. So in platinum resistance, there was in fact detrimental effects seen. The rest of the other things are all voluntary callback. So this particular setting, when you have a defined platinum resistance, in presence of even mutation, we are not using PARP inhibitors.
I think the time is coming to a close, but just a couple of last questions. And Nikhil can also have a few questions. What is the peritoneal carcinomatosis index?
sir, that is we divide the abdomen into 12 quadrants, and then each points are given based on the size of the tumor in that, based on the less than 2 centimeter, 5 centimeter markers are given, and then we add everything, and usually more than 20 is a poor prognosis, less than.
And how is it usually done? The ideal way to do it?
It can be done radiologically, sir. Ideal way would be a intra-op assessment of
staging laboratory. And what is the role of after a couple of relapses, even though the PDL1 was negative for this patient, what is the role of immunotherapy for this patient? Would you suggest that?
Role of immunotherapy, there is only the tumor agnostic role, sir. We can give
so PDL1 was negative.
dostarlimab or PDL1 was negative. Based on tumor mutation burden high, then we can consider
TMB or
what is the other thing?
Garnetrel, dostarlimab.
Dostarlimab, not pembrolizumab. You're not interested in pembrolizumab. Would you do an MMR for this patient?
MMR, yes, sir. Can do.
Nikhil, anything else?
I think we tried to cover all the settings reasonably. I think the clinical part, obviously, keep in mind some of the closer DDs. How do you differentiate uterine versus, I mean, just to complete uterine versus endometrium? Rarely, if you get a tubular cancer, also, what is a classic symptom? You have that hydrops tubae features. That's one of the few DDs where an epithelial cancer can present with discharge per vaginum or serous discharge per vaginum. Sir, if that's it, we'll end the things up. I would like you to give some feedbacks in the positive way to Dr. Lakshmi.
Yeah, I think means you're prepared very well with the clinical trials, etc., and all those things. But trust me, most of the examiners might not go deep into the trials. They don't. They're not so much bothered about the numbers and the trial names and all those things. But you should know how a concept was evolved, and I think you demonstrated like what is the concept between dose dense and the other? What is the concept for HIPEC? What is the concept for platinum sensitive relapses? Concept for PARP inhibitors, etc. You need not know the trials by name, but you need to just know what are the advantage of all those things. You did that, and just concentrate because this is a new, because this is upcoming. This thing concentrate a little bit on the molecular parameters also, as well as we didn't go too much into the molecular side for want of time because that is the next level. You will be learning that slowly, but keep in mind about the molecular alterations in ovarian cancers, not only the BRCA, but the other HRD parameters and beyond HRD also those things. And the one thing that many people will be asking is the family history and the hereditary cancer plus ovarian cancer related questions. You can expect questions related to that in the Viva at least. Certainly, there will be more and more questions coming up in the hereditary cancer arena. So
And the
overall,
questions may come upfront during your that family history presentation. It's most of the times the questions will come about HBOC over there.
so don't just get carried away by the diagnosis. Most of you will get the diagnosis before the exam itself. Never get carried away by that. We know that everybody will be getting the clue for the diagnosis previous to prior to the exam itself. But still, we can play around with the differential diagnosis, etc. So just stick on to whatever differential diagnosis you feel like.
So one
Okay.
comment, well presented, Lakshmi. If this is how you're going to present the finals, also it should be fine. But as sir said, just do some fine tuning of you defending the differential diagnosis. I keep telling everybody that at the end of the day, it's like arguing a court case. There's no right or wrong. It is what evidence you're in favor of your DDs. In fact, most of the time, we to just get a comprehensive thing because we have a lot of we try to complete with the management. Most of the time, if you reach management and even trials, probably are clearing through. Just fine tune your exam. What are your basics? What do you look for? What are your basic radiology, your basic pathology? And you have done very well actually today.
Thank you, sir.
Great. All the best. Are you a final year?
Yes, sir. Fine. Then.
Yeah, all the best for the exam.
Thank you, sir. Thank
All
you.
the best to you. Sir, I think with that, we will conclude the meeting for today. I think we had more than 200 participants. It's good to see that we are able to coordinate, and also it's a learning experience being with Sunu sir for me also. And these are all these questions are traditional. This will be asked. I don't think any of them are bouncers and thing. If the exams come for these, all more or less, I've heard variations of this with different, whichever exams I've been a skilled expert or I've sat in or even which I have attended, all these have more or less been covered, or the similar scenarios been covered. If that is all, good night to all of you and all the best, Dr. Lakshmi.
Thank you, sir.
Sunu sir, bye.
Nothing. Good night.
Boban sir
Bye.
is-
Good night.